Thank you. Thank you all for coming. We're here to reflect on a recent event in Serbia where, due to obstetric violence, a baby lost her life. It is not the first nor the last time this has happened, but we believe it is important to talk about this matter and not let it pass unnoticed. It is a very complex issue. Women have been facing all sorts of discrimination and violence for centuries. In a recent survey on obstetric violence in Serbia, the majority of women reported that the communication with the medical staff was unsatisfying and rude, and that at times they didn't know what was happening, but were afraid to ask, or if they did, they weren't given a satisfying answer. Obstetric violence is only one form of violence, but it happens when women are at their most vulnerable. Today we have 4 guests who are all fighting against discrimination and for human rights and the rights of women. Unfortunately, due to unforeseen circumstances, Dr. Pickles wasn't able to join us today. We're going to try and tackle this very important topic and hopefully come out the other side with more information, confidence, and strength to prevent obstetric violence from happening. Before I introduce our guests, I will just give you the outline of today's panel. In the first hour, each guest will answer one question. They will have 10 minutes to do so. After that, they will continue with an open discussion of the topic, and in the last 15 minutes or so, they will answer some of your questions. As you can see on your screen, there is a chat and a Q&A button. If you want to chat between yourselves, use the chat option, as questions from there will not be read. But if you want to ask one of our panelists a question, use the Q&A option. But please do not ask any personal questions, just the questions that relate to this topic. And now let me introduce our dear panelists. Alicia Yamin is a lecturer at Harvard Law School and Harvard T.H. Chan School of Public Health, as well as a senior advisor on human rights and health policy at the global health justice organization called Partners in Health. Her work includes economic and social rights, sexual and reproductive health and rights, the right to health, and the intersections between development paradigm and human rights. Liiri is a human rights lawyer working for the Estonian Chancellor of Justice. Liiri advises the Chancellor on human rights law and leads human rights research projects. Her academic research investigates gender, violence, and shame narratives in sexual and reproductive rights, jurisprudence, norms, and practices. Ivana Krstić is a full professor at the Faculty of Law, University of Belgrade, where she teaches international human rights law. She is director of the Institute for Legal and Social Sciences and director of the Human Rights Center at the Law Faculty. She's engaged in initiatives that aim to mainstream gender in all legal disciplines. She has provided expert opinions on anti-discrimination legislation and has supported many international organizations in their gender and justice work. And finally, Milica Ninković is a research assistant at the Faculty of Philosophy, University of Belgrade, where she is also working on her PhD dissertation. She has been involved in projects dealing with women's trust and confidence in the health system, psychological dispositions to questionable health practices, and developing gender equality plans. Now we can start with the panel. First question is for you, Professor Yamin. What is the history of the concept of obstetric violence?
Thank you so much for inviting me to be part of this panel and to contribute to what I think is a really important interdisciplinary conversation. I am going to share my screen because I have a few slides with which to answer that question. Can everybody see that? Okay, so I actually want to go back a little bit, give you some historical context for something that's called disrespect and abuse, which is different from obstetric violence, but really fundamental for us all to understand if we're going to understand what obstetric violence's innovations are. And then talk a little bit about growing jurisprudence and open questions. So Many women experience mistreatment during childbirth. This happens around the world. It tends to happen to more vulnerable populations more at a higher rate than others, but it happens all around the world, and I'll refer to some data in the United States later. So I want to pull us back in time to the Millennium Development Goals. After the 1990s, where we saw a series of kind of trans-sectoral development conferences, including, very importantly, a conference on population and development in 1994 and a conference on women's rights in Beijing in 1995, where the idea of development and progress was conceived of as political change and institutional change and empowering women to be at the center of development, trusting women to be decision makers over their reproductive capacities, not as opposed to imposing demographic imperatives on them, pro-natalist or antinatalist. Then we went through a major shift with the Millennium Development Goals, which were a very top-down, technocratic agenda, in many ways incorporating backlash to the reproductive and sexual rights agenda in Cairo and Beijing. There was not any mention of sexual and reproductive rights, except for this one target on maternal mortality, which was considered to be a real scourge at the time, and indeed it was. I've worked a lot on maternal mortality. So the one goal on anything relating to reproductive health was improving maternal health. And the target was reducing by 3/4 between 1990 and 2015, the maternal mortality rate. And the indicators that were used, and this may seem distant from what we're talking about, but I hope to show you that how we think about these concepts and how we measure them has an effect on real women and embodied experiences. So the indicators that were selected at the time to measure this were maternal mortality ratios and skilled birth attendance. It was only later, in 2007, that universal access to reproductive health and family planning methods were added as well. So what happened during the Millennium Development Goals? Well, skilled birth attendance became institutional birth. Skilled birth attendance is hard to measure. It's measured through surveys conducted by UNICEF, for example, the mixed surveys. And people who are asked are often illiterate or don't know whether they were attended by a skilled birth attendant. So they answer based on whether they gave birth in a hospital or not, whether or not the attendant was actually skilled in midwifery skills, which is what the indicator requires. So this move toward institutional birth, which was pushed by the World Bank in a very big way, included the use of police to actually escort women into facilities, imposing quotas for health providers to deliver women, the withholding of birth certificates for women who decided to deliver outside of health facilities. So if you can't get a birth certificate for your newborn, obviously they're excluded from a whole series of human rights. It included criminalization of traditional birth attendants in many countries, especially in Latin America. And it included detention in facilities. So detention, for example, there have been a number of litigations around this in Kenya, Uganda, largely in sub-Saharan Africa, but not exclusively. This also happened in Eastern Europe. So what do we get from this mix of policies? Massively overcrowded health facilities that are breeding grounds for disrespect and abuse, and not necessarily equipped with the capacity to resolve obstetric emergencies, right? Which was the whole underlying premise of having skilled birth attendants as an indicator. In some cases, pregnant women, because the push toward having women deliver in facilities was not met with commensurate increase in funding and financing from the global community, we see things like this news story in Cameroon starting to pop up, where women are pushed to deliver in facilities, but the facilities themselves don't actually have the resources and don't want the women to deliver in facilities. We also have a lot of punitive approaches to health workers during this time. So in some countries, you see efforts to eliminate user fees in health facilities. So this has been a highly touted case by Chatham House, which has been behind getting more people to deliver in facilities for a very long time. And that you eliminate user fees at the national level is a good thing, but it doesn't mean that that money actually trickles down to the subnational district level or the facility level. So you see in cases that I've worked on in litigation in Uganda, for example, where user fees were eliminated, women were encouraged to give birth in facilities, and yet at the point of service, women are still required to buy their own mama kits or birth kits, right? So there is a mismatch between what we think we're doing in terms of policy and what is actually happening on the ground because of a non-alignment of policies, because of corruption, because of a whole series of things. So there are some issues with disrespect and abuse, which is the concept that is used by the World Health Organization and a lot of other kind of mainstream global health institutions. You see widely varying prevalence rates of disrespect and abuse based on how it is defined, as well as how is it measured, right? Is it measured by interviews with women who are still in facilities and literally under the control of the health providers about whom they might want to speak negatively? How long do we have to wait before getting a more accurate read on what actually happened? How much do women who have been accustomed to being mistreated their entire lives by systems in society, as well as by men often who control them, undervalue their own experiences of abuse and neglect and mistreatment? All of those are big issues in how we measure disrespect and abuse, and to some extent in how we measure obstetric violence. So moving forward and trying to create a program that makes a difference in this field has some serious measurement issues and methodological issues to deal with. I want to underscore that maternal mistreatment is an enormous problem in the United States and in high-income countries, as well as very low-income countries. The pictures that I showed of sub-Saharan Africa are largely because they are so dependent on aid, like, for example, during the Millennium Development Goals, that those indicators and targets affected their health planning in very acute ways. But maternal mistreatment is not just a subject out there or then. It is now and here in the United States and other high-income countries. In the United States, the real issue are racial disparities, right? Racism, structural racism pervades our medical system. And when you have intersectional inequalities of gender, race, sometimes language, and educational or class differences, it makes for a terrible combination in terms of women's experiences in delivery and childbirth. So obstetric violence, now getting to the topic of this webinar, has a somewhat different genealogy. It really came out of Latin America at a long time feminist organizing in Latin America for parto humanizado, humanized childbirth, and then going into obstetric violence, which has its is related to other kinds of gender violence, right? It's the way in Latin America movements for abortion rights have focused on abortion and draconian restrictions on abortion as a kind of gender-related violence. So there are lots of connections in the Latin American feminist movement. This is a picture of me at a symbolic tribunal on obstetric violence that was held in Mexico City in 2015. And I'll point out, not me, but this woman here who is on the CEDAW committee. And the CEDAW committee has issued some of the most important jurisprudence from a supranational tribunal regarding obstetric violence. So how is it different from disrespect and abuse? Well, it has been enshrined in legislation in a number of Latin American countries, as well as elsewhere, and subnational in federalist states, subnational legislation like Mexico. The definition in Argentina is violence exercised by health personnel on the body and reproductive processes of pregnant women, expressed through dehumanizing treatment, medicalization, abuse, and the conversion of natural processes of reproduction into pathological ones. So, first of all, I think the definition can move beyond women now for all subjects that are gestating, all reproductive subjects, as Rachel Chadwick uses that term in her work. But it takes into account not just the kinds of mistreatment that disrespect and abuse does. It looks at unnecessary procedures, for example, episiotomies that are widely used, or unnecessary cesarean sections, unnecessary use of Pitocin, for example. It looks at failure to provide adequate information to reproductive subjects during their pregnancy in which they could, or childbirth, in which they could make more informed decisions. And it looks at structural determinants in health systems, those issues of financing and overcrowding, of appointments with providers being, every 15 to 20 minutes, the scarcity of healthcare providers at all due to underfunding of health systems. And it also asks us to focus on the importance of background and informal norms, because so much of obstetric violence is not because of legislation. It's because of the relationships that are sort of taken for granted within health systems, hierarchies, thoughts about what information do women really need, right? Hierarchies between providers and nurses, for example. Background norms on that speak to gender stereotypes about what women or what reproductive subjects are really capable of. They inform this pathologizing of reproductive processes. And I'm happy to talk about that more in the Q&A. So to me, what is exciting about obstetric violence is that it not only looks at the health system, it denaturalizes those inappropriate practices and abuses and neglect that are taken for granted in the mainstream paradigm. And it says these are not just lapses in quality of care. These are violations of dignity and rights. It defines appropriate measures. That's absolutely critical in reproductive health, sexual and reproductive health. That, for example, episiotomies are not standard of care, right? And that has been enormously important in advancing the right to health in general in international and comparative constitutional law, and is especially valuable in this arena of reproductive health. But the third thing that really makes it so extraordinary is that it conceptualizes reproductive health issues as a matter of social and power relations. It really constitutes a challenge to medical authority, right? It's one, natural processes of reproduction are not diseases that are happening within individual bodies. They are natural processes, and the way they turn out is affected by these social and power relationships, and is not just something to be determined by the unchallengeable authority of clinicians or researchers. So that, I think, is the most exciting thing. It really disrupts the biomedical paradigm of doctors and providers and the medical profession always know best, and women are passive recipients of those services and attention without dignity or agency.
One more minute, Professor
Okay,
Yamin.
I'll go through this very quickly then. So I think there are some open questions that I hope we'll get to. One is remedies. If we're calling this violence, what kind of remedies are we expecting? We've been through this in feminism with domestic violence and the failures of carceral approaches, and the failures. We don't generally want criminal law mixed in reproductive health. So I think that's still open to say. The jurisprudence, I'll go through this quickly. The jurisprudence is quite mixed at the supranational level. CEDAW takes a much more of the kind of perspective that I've taken. The case that was at the Inter-American Court is really about dramatic violence perpetrated against a woman who had a miscarriage and was penalized criminally for trying to kill her fetus. So very, very different things. And I think the jurisprudence needs quite a bit of development at the international level as well as national. And the third thing is that in the right to health, generally, we have worked very hard not to develop punitive approaches to frontline health workers, but to look at the entire health system and figure out how to democratize it. So looking at legal and policy frameworks, to national strategies and plans of actions, to how the budget is aligned with those, program implementation, et cetera. And really make it not just that patients have a claim against their providers, but that service providers also have entitlements and claims against program designers who may be, who throughout the circle are affecting what could end up being obstetric violence. Program designers have a claim on politicians. Politicians and policymakers have a claim against the legislators if there are not sufficient budgets. And in this case, I think there's also, a room to expand the idea of obstetric violence to look at the role of private actors, in health systems that are increasingly privatized, financialized, and beholden to pharmaceutical industry interests, for example. So all of those things, I think, are open to the future, and I look forward to hearing others' thoughts. Thank you.
Thank you very much, Professor Yamin. Now a question for Professor Oja. What are European and Estonian data and experiences on the matter?
Thank you. I will also, well, thank you for inviting me to this panel, and I'm really happy that there are so many people. I can see 50 people attending, and actually quite a few names that I recognize from Estonia, so I'm happy to know that people are also listening in. So I'm going to also share my screen. I only have 2 slides, but just I think it's a bit easier to follow if you have something. Okay, can you see my slides? Can I get yes? Okay. So I work in Estonia, but so currently I'm on parental leave, so that's the disclaimer. So officially, these are not the views of the Estonian Chancellor of Justice. In Estonia, we do not, unfortunately, have any large qualitative or quantitative studies on the prevalence of obstetric violence, so I cannot really give you any data, any numbers. And actually, what Alicia mentioned, we haven't even really done the work of deciding the methodology. What would we actually measure and how? What are the definitions? This is also something that hasn't been done in Estonia. I know that there are some university level master's thesis and also undergraduate thesis, but there is no like a large study. So this is definitely something that hopefully will happen in the future. But a few years ago, there was a social campaign by an NGO. It's Mina ka sünnitajana. So if I translate that into English, it's like me too as a person giving birth. It asked people to submit, if they wanted anonymously, their birth stories. And I think they ended up collecting, for Estonia, that's a good number, hundreds of stories. And many of these stories spoke about mistreatment, verbal abuse. Just to give you the context, so obstetric care is very good quality in Estonia. It's modern, it's high level, maternal mortality is very low, almost zero. And the care, whether it's prenatal care during the birth or postnatal care, it's for free for everyone. So even if you're not insured, you don't have health insurance, but you become pregnant and it's established that you're pregnant, you have the access to all of these prenatal screenings. You can give birth at the hospital. Of course, there are some access issues in more rural parts. So not everything is perfect, but just to kind of give you the context. But then at the same time, not just the NGO campaign, but also I've been doing trainings for healthcare professionals, not specifically on obstetric violence, but human rights-based approaches in health. And because my specialty is sexual reproductive rights, I've worked with OBGYNs and midwives. And in those trainings, it has also come up that there are many personal narratives that are reporting shaming, pressuring, for example, a midwife or a doctor telling a woman, well, you have to choose this because this is best for the baby. Or there is just no communication, women saying, I did not know what was happening to me, what was done to me, no one told me, or belittling the experience afterwards. When a woman does understand that not everything was the way it should have been, there is a lot of belittling, but you have a healthy baby now, so why are you complaining? So in the Estonian context, we have many questions to still unpack, and I'm hoping there will be a thorough research initiative doing that. Starting with the methodological question, what is obstetric violence? What does human rights-based care actually look like? And I think one of the very important questions that I've had during my trainings is even some of the healthcare professionals actually do not see that the work that they do is human rights work. So bringing these two worlds together. And also the impact of structural problems, work overload, people not getting, healthcare professionals not getting paid enough. And what is violence in reproductive and sexual health and stereotypes about women. And I've also seen in those trainings that there are sometimes these generational differences, the historic context, what was accepted during the Soviet occupation in the field of sexual and reproductive rights, and how is the contemporary context, because the historic context is I would argue is influencing a lot of these problems that we have. And also in the medical education, what are actually midwives or doctors, future midwives, studying and learning about human rights-based approaches in healthcare institutions, And how does that actually work in practice? Because I've also encountered that I talk about consent, but then I have a young doctor telling me, but the hospital is giving me 15 minutes or 20 minutes to talk to that patient. So, I cannot do all of what you're asking me to do. So all of these questions. So our work at the Chancellor's office, we do not have a huge focus on obstetric violence or even sexual reproductive rights, but I can give you a few examples, and one of them is actually not on the slide, but Alicia mentioned it. So we have had cases where people, because home birth in Estonia is legal and some people choose that, but there have been cases where after a home birth, a family has not been able to secure a birth certificate. We had a few of those cases at our office. They have been resolved for now, but this is definitely a part of that conversation. But then during COVID-19 pandemic, during the first year, we had many women turning to our office because there were other restrictions as well. People giving birth had to do mandatory testing and wear masks. But one of the issues was also that they were not allowed to bring birth partners, whether it was a husband, a partner, just a family member, even a doula. And of course, it was a very different context. And the conversations are really difficult because from one way we understood the risk, but then also a birth partner, we had to explain to the hospitals, to the Minister of Social Affairs, having a birth partner at one's birth is not just something, about convenience, but it is part of the human rights-based birth experience, positive birth experience. And in some cases, it can also be a question of language. For example, if someone who only speaks Estonian sign language is giving birth, then they might need that a birth partner, family member, doula, who is also translating. In the end, these restrictions were lifted, but we're not always making the link that it might cause obstetric violence, but this is part of that. And another example, our office is also doing inspection visits to prisons, and because we are the monitoring body for the non-degrading treatment and torture prohibition. So from the UN Convention, we focus on also on the human rights of imprisoned people. And one of the things that has come up is that when these are rare cases, we do not have that many cases, but when women who are detained and in prison have gone to hospital to give birth, there have been issues with them being shackled and also having a male guard being present in the delivery room at all times. And we've had the cases from 2016 from one of prisons, and then again, let me just check so I don't tell you the 2022, again, a different prison. And yes, this is not something that is committed by healthcare professionals, but it is in that context. And sometimes these conversations revealed that it's not just the prison institution that is doing this analysis and arriving to the conclusion that we need to shackle a person giving birth, but also sometimes the hospital is also not really pushing against that because of that security analysis. So we have had to explain that, for example, instead of having a male guard present in delivery room, a prison could use the prison nurse, who anyway does a lot of medical work with imprisoned people. And shackles we have argued that should never be used, but if used during transport, there needs to be a very well argued case for that, and it cannot be this blanket argument that a person is prisoner, so therefore they're dangerous. So that's for Estonia. How much time do I have left? Do I have a few minutes?
Maybe 2 or 3 minutes, yeah.
Okay, so it's a very busy slide, and I'm not going to go through all of that, but just I thought I will put all of these references on a slide if someone wants to take a photo of this slide. So you have the international references. One of the important reports is the report of the UN Special Rapporteur from 2019, and she was focusing on childbirth and obstetric violence, so that's an important milestone. Alicia already mentioned Inter-American Court and also CEDAW committee. So these are the more recent cases. And I want to, Alicia kind of already said that, but I want to highlight myself that because I've looked at international jurisprudence in sexual reproductive rights for many years, since my PhD and from the beginning of my PhD. And these obstetric violence cases that come from CEDAW committee, for example, we have to understand that there's been a lot of work happening before there needs to be this understanding of gender-based violence being a human rights violation, and how power relations play into childbirth, for example. So this brings me to the European context, and the European Court of Human Rights has not ever referred to obstetric violence in its jurisprudence. It has acknowledged obstetric care and birth being issues of human rights and found rights violations, but it has not adopted the language of the obstetric violence. And I think we will not be seeing that language being adopted too soon. There are these home birth cases that I've marked with that blue little line. And home birth cases are important because we have to think, why are people so, well, let's use the word desperate, but sometimes so adamant to give birth at home? And if we read these facts of these cases, we always see that these people already have experience with the hospital setting, and something has gone really, really wrong there. So home birth cases for obstetric violence jurisprudence are very important. And right now, there might be more, but as far as I know, there are 2 pending cases at the European Court of Human Rights. So we'll be seeing more of the analysis, but I wouldn't have too high hopes for that. I will stop here, and if you have any questions, I'm happy to take them now, or if someone is too shy, you can always send me an email. Thank you.
Thank you very much. And yeah, I hope people will ask questions in Q&A option, and then we will answer them after the first part of the lecture. So now a question for Professor Krstić. What do we know about current conditions in Serbia in regards to obstetric violence?
Thank you, Jovana, for this question. But before I go further, I would like to refer to what Liiri said, because what's happening in Serbia in terms of legal framework, because Milica will talk more about some very comprehensive report that was produced in Serbia, illustrating what's happening in Serbia. I would like to more concentrate on that legal framework, and there is the possibility for victims of obstetric violence to provide legal support and redress. And Liiri mentioned, and also Alicia mentioned, CEDAW. I would also like to mention one report of the UN Special Rapporteur on Violence Against Women, which was produced in 2019, where basically the UN rapporteur said that the root cause of obstetric violence includes labor conditions, resource limitations, and power dynamics in the provider-patient relationship, which are compounded by gender stereotypes. And this is what also Alicia underlined in her presentation. We, as a part of this international regime, but also as part of European regime, and Liiri already mentioned some cases, very limited cases decided by the European Court of Human Rights. We are also a member to Istanbul Convention. This is the Convention on Preventing and Combating Violence Against Women and Domestic Violence. And this convention was introduced or adopted in 2011, so it's like 13 years ago, but there is no mention of obstetric violence in this special convention as well. There are some references, for example, Article 39, which can be used also in cases of obstetric violence, but we don't have definition or mention of this form of gender-based violence, which also shows and illustrates that this kind of gender-based violence, this form of gender-based violence was not in the core of international community and European community at that time. What I would like to underline is that a legal background in Serbia is also very much aligned to what we have as this very weak legal regime. And the adequate legislation is a good starting point, but because it, first of all, empowers women and their families to claim their rights to health care without any discrimination. However, I have to say that in Serbia, we don't have any specific provision which recognizes obstetric violence within the Serbian legal system, and it's a limit by itself. It does not mean there is no redress, and there is no legal way to claim redress in a case of obstetric violence. And I would like to underline that the Constitution, between the main principles, also stipulate gender equality. And we also have a very a broad anti-discrimination clause, which is also enshrined in our constitution. And as the constitution was adopted in 2006, we introduced a special legislation on discrimination in 2009, and this law was amended in 21, so 3 years ago. But what is interesting is that we don't have any mention in the law on the prohibition of discrimination, that special law, any reference to obstetric violence at all. We also have a very specific law on gender equality, which was introduced again 3 years ago. But again, there is no express reference to obstetric violence whatsoever, which is really a challenge. And especially as we already had the very important cases, Liiri put them on the slide against Spain, for example, where CEDAW committee for the first time acknowledged obstetric violence, but there is still no reference in Serbian legislation, and especially this one, which is very specific and deals with gender equality itself. Of course, that the law prohibits any form of gender-based violence, which means that we can also refer to some specific provisions, but as I said, no specific mention of obstetric violence. And also, I would like to underline that we have some provisions within the law which refer to social and health protection. We also have one provision which refers to sexual and reproductive health rights, and also stipulates what is the duty to relevant ministries, which need to ensure that all individuals have the right to access easily accessible information, education and services in relation to different aspects of their reproductive rights. So it is interesting to underline also that we have policy documents which are relevant in this area. And again, we have one policy document on gender equality and gender equality strategy that was again adopted 3 years ago. And here in this strategic document, there is a specific section on health protection. But at the same time, we don't have the mention of obstetric violence, which is very interesting. However, what we have in this policy document is reference to Roma women and women with disabilities, which are exposed to multiple discrimination, so multiple forms of discrimination. And also the strategy very much refers to women and girls with disabilities who live in residential institutions, because the strategy says that they are at great risk because they're exposed to forced sterilization, to forced abortion, to administration of contraceptives without informed consent, to sexual harassment and sexual violence. So this is what we have in our policy document, and this is a very important reference because no matter that, for example, I refer to that document from 2019 when the UN Special Rapporteur said that this form of violence is very widespread and it happens to all women, no matter of their background. We still have those which are more vulnerable or susceptible to this form of discrimination. Then we also have some other laws, such as, for example, the law on health protection, which gives us some main provisions on principles that need to be provided in a healthcare sector. And one of them is also the principle of human rights respect, the right to consent, the right to information. So all of them which are common which are violated in cases of obstetric violence. What are the available remedies to those when, for example, this form of violence happens? We have many internal and external mechanisms available in Serbia. So first of all, the patient can complain to the health worker, to the director of the institution, to the head of a certain department. We also have some specialized external mechanisms, such as the Chancellor for the protection of patients' rights. Then also the Ministry of Health monitor the work of the specific institution, the health inspection monitors and examines the expertise in certain cases. We also have the medical chamber, the court of honor, so different specialized mechanisms, but also what is available in these cases are some general mechanisms. For example, the Commissioner for the Protection of Equality. And I mentioned this law, which was adopted in 2009. And no matter that we don't have the mention of obstetric violence in law itself, at the same time, it is a form of gender-based violence and a form of discrimination, and someone can bring the complaint to the Commissioner. In reality, we had only one complaint which was submitted to the Commissioner in 2022, and it was anonymous. So it was dismissed, unfortunately. After the latest case that we had in January this year, the Commissioner announced that she will introduce a general recommendation to all health institutions, and one of her recommendations will be the training of medical staff, and also to monitor the protocols, existing protocols within medical institutions. There is also possibility to submit complaint to the ombudsperson, which is another independent institution in Serbia. And of course, there is a possibility to go to mediation or to civil courts to seek monetary compensation, and of course to criminal procedure, to initiate criminal procedure for different acts. But again, in our criminal act, we don't have a specific act which refers to obstetric violence, and there are some limitations to it. So what we can conclude from available data, and I have to say that in terms of legal remedies, we don't have many data, and I think that data is really relevant in this area in order to provide more information on not only in existing remedies, but what's happening in practice, and why women decide to not to report the case to all these mechanisms, which are so much widespread in Serbia. So what we can conclude is that we don't have many reported cases, that in all cases we have problems with the evidence and with witnesses, what really happened. There is a solidarity among medical staff and lack of information on specific cases. Then mitigating circumstances are often taken into account, which means that we have maybe only a few sentences in criminal procedures, but sentences are really extremely mild for this kind of gender-based violence. And also what is noticeable, and it's not only in these cases, but also in other cases, discrimination cases, as the presence of gender stereotypes and prejudices among administrative and judicial bodies, that, of course, limit the access to justice and results of the case and affects other women not to report the cases. So it's some kind of circle that we are living in, why legal remedies are not so effective in this case. So I will stop here, because for you it would be much more interesting to hear from Milica what the report said on different forms of obstetric violence that is happening in Serbia.
Thank you very much, Professor Krstić. So then now a question for Mrs. Ninković. What is the situation like in hospitals in Serbia at the moment? And later on, if you can tell us about the specific aspects that Roma women have to deal with in regards to obstetric violence and childbirth as a whole.
Yeah, thank you, and hello everyone, and thank you for inviting me to speak here. So I'm gonna talk about obstetric violence from sociopsychological perspective, which is actually something that I've been working on with my dear colleagues Kaja Damjanović and Sandra Ilić, who also come from University of Belgrade Faculty of Philosophy. And it will actually not include only the data from one report, but I'm going to try to, you know, just to comprehend as much as possible. So I would start with an example that is not actually it is not particularly obstetric violence, but if we talk about material conditions in maternity hospitals, on average, they are actually worse than in any other kind of hospital, which indicates us the structural relation between society and birth-giving women. Why? Well, we all know that giving birth is seen as something sacred in our society. But we also, at the same time, put women to give labor, to deliver babies in really, really bad conditions, like you know, in all the dirty beds, to use bathrooms that are not cleaned and stuff like that. And actually, it is the indicator of how society treats women as a group, and not only women who are giving birth. So actually, the society normalizes the humiliation of women during childbirth. But of course, this is a systemic problem, and it is out of the scope of this discussion. I just wanted to illustrate the relation between the system and society on one side and women on the other. So when we talk about obstetric violence and its different aspects from the perspective of women in labor, we can map a few categories. Which is, first of all, objectifying women's body, then absence of any communication and silent treatment of women who are giving birth, roughness of medical staff, and also some kind of privileged treatment for those who give a bribe to doctors. And these first three categories, so objectifying women's body, absence of communication, and roughness, they actually imply that the women are expected to be passive, although their involvement is necessary for the labor to be effective and less painful and safe and stuff like that. So here we have a kind of paradoxical expectation where, on one hand, we want women to, well, medical staff wants women to be involved because it is necessary for the childbirth to be like safe and effective, but also not to ask questions, not to be loud, not to express their emotions and stuff like that. So actually, they are passivizing women in some way. And where is this paradox stem from? So it is actually the consequence of the complex interplay of a variety of factors. First one is a lack of resources in the healthcare system. So our healthcare system is understaffed, staff is underpaid, they're in burnout. But of course, I mean, we have to address this, but it is not something where we can intervene like psychologically or socially. So it is the question of system and financing and stuff like that. But the other factors are also important. So first of all, it is patriarchal representation of women. women are supposed to be submissive and quiet, but at the same time, they are perceived as hysteric, highly emotional, and all of these attributes that we are usually faced with. And the other important factor is our power relations, and it was actually already mentioned by previous speakers. So power relations between medical staff and patients, where patients are expected to be obedient, but we will see why it can be, but doesn't have to be a problem if we change the perspective. So I will just first focus on this patriarchal representation of women. So when women talk about negative experiences during childbirth, they are usually silenced, and you have probably heard those arguments like your grandma gave birth in the field, you're so spoiled, you're ungrateful, and stuff like that. And then the important issue here is that these comments come from people of all ages, genders, professions. So it means that on average, people think that women who complain are ungrateful and spoiled. And what is the problem? I mean, this malevolent narrative has so many problems. And the first one is that it silences women. So it actually it maintains that vicious cycle of violence. Why? Because if a woman says, I suffered during the childbirth, and someone says, oh, no, you didn't, you're spoiled, then she will not speak about that anymore, because, it's like gaslighting and invalidating. And then the other women will not know that they could expect some similar treatment. And also here we have, the other problems with this narrative are a huge, they having the experience of obstetric violence is of course traumatic, and this kind of gaslighting can enhance psychological trauma. And we know from the data, not only from Serbia but from all over the world, that experiences of trauma and obstetric violence then can lead to a higher risk of post-traumatic stress, postpartum depression, psychological distress, and stuff like that. And then we have those women who are left without any systemic psychological support. And they are also, not only that they, are just left with their newborn baby and with that new role of a mother, but also with a huge trauma. And then they're also less likely to decide to give birth again. Which means that this is not only problem, it's not only problem for women, it's not only a feminist issue, although it is a feminist issue, but it is also a problem for demography of every state. And here we also have that culture of not trusting women. It reproduces obstetric violence, and we talked about, and Professor Krstić also talked about that vicious cycle of violence. So women are not aware that many other women went through similar experiences, and then that whole non-human treatment is normalized, which leads to not trusting other women that went through this. And as a consequence, the cases of obstetric violence are represented as an exception rather than a rule, although they seem to be very, very frequent. And the other factor I would like to talk about are power relations. So we said that physicians and nurses who all have professional authority and are supposed to know how to lead a woman through labor and how to help her if anything goes wrong. So they're on one side, and they actually have power over laboring women who are at one of the most vulnerable moments of their lives, going through a painful and maybe unknown experience. And it is the situation is clear. So medical staff does have an authority and power, but the question is not, do they have authority and power? The question is, what are they going to do with that power? So they can decide either to use it, to use their professional knowledge and experience to make a laboring woman feel like a human being, or they can decide to humiliate her and treat her as less valuable just because she is vulnerable. And unfortunately, on this continuum from full appreciation of her to full humiliation. There are many cases that are near this humiliation extreme. I mean, they are not rare. And now we come to actually the other question that is about Roma women, because it seems that some women are less equal in this power play. So we have like women from higher economic classes, they have an opportunity and they have resources to, if they need to give bribes to the medical staff. And that serves as some kind of a guarantee that they are going to be treated as human beings. I mean, I don't think that it is good, but it happens. So it's our material reality. They also have an opportunity to give birth in private hospitals that are usually less understaffed and usually offer better conditions, which means that unprivileged women from lower economic classes, women from minority groups are at higher risk of experiencing obstetric violence. And this is especially true for Roma women, because when the widespread misogyny and class differences meet systemic racism, then it is like, I mean, they're so unpowerful and so vulnerable that people think that they can do anything to them. And I mean, just to put it in the context, Roma minority is the largest ethnic minority in Serbia, but also the most discriminated against, and they face systemic discrimination. So they usually, I mean, there are huge problems because system does not recognize them. And I mean, this is out of scope of this discussion, but I just wanted to put it into perspective. So the lack of privileges increases this power gap that I was talking to between Roma women on one side and medical staff on the other, and then this systemic racism just boosts that power gap. And as a result, Roma women are often dehumanized and treated without any hint of dignity. So they are less likely to be trusted, their experiences are less valued, they are also less likely to be informed about the procedures that are carried out on them. And as a consequence, they are at higher risk of long-lasting physical and psychological consequences of obstetric violence that are also unlikely to be treated because seeking for psychological support is stigmatized, and also there is not free of charge mental health services are not so widespread. So I mean, they cannot always ask for help. And I would like just
one more minute. Sorry, Ms. Ninković,
yeah,
one more minute.
Perfect. I just need a minute. So I would just like to conclude with what is it that we can do to change? So systemic changes that require material resources and the willingness of the authorities. I mean, they are huge and we cannot change them overnight. And it is something that is, of course, much bigger than this. But there are smaller things that are inexpensive and that can at least help lower the incidence of obstetric violence. So first of all, only following the guidelines by the World Health Organization about childbirth should lower the incidence of unnecessary interventions such as episiotomy that can hurt a laboring woman. Second, treating a laboring woman as a human being that has a right to have normal reactions to pain instead of mocking her and shouting at her is something that should be a rule and not an exception. And also as a society, we should listen to women's voices and trust them and motivate them to talk about their experiences. And finally, physicians and nurses have not only the responsibility, but also power to change the current situation by giving the laboring women some agency. And this is actually, so they can give them voices, they can let them be active participants of their labor. And this is how maybe this vicious cycle of obstetric violence reproduction can be broken. Thank you.
Thank you very much. Thank you all for answering the questions in detail. You gave us a lot to think about. Now we can start the open discussion. In order to start solving the problem of obstetric violence, it is necessary to get familiarized with some guidelines and understand how some other countries are trying to deal with it. So could you, maybe Professor Yamin and Professor Oya, could you give us some examples of good practices and tell us what could be done on a practical level in terms of laws, professional association rules, patient protections, etc., that Serbia could or should implement? And then also Professor Krstić and Mrs. Ninković could also contribute and say what maybe they think could be done on a practical level here.
Ali, do you want to go first?
I was just going to ask you the same thing. So I think there are clearly good examples of adopting legislation, right? From a number of different Latin American countries, but also from other countries around the world. And changing other laws as well. We're not going to have legislation on obstetric violence in the United States, but this comes into civil liability for certain issues as well. I think that beyond changing the laws, there's a massive change in consciousness that is needed, which goes to education of providers, and in many ways revamping the curriculum to approach medical practice with, as Lisa Cosgrove says, more humility instead of so much hubris. I think there are protocols and regulations to issue within health sectors, but this is not just a matter of imposing rules, as I said in my presentation, and I think was echoed by many others. These are informal norms that permeate health systems, based on things like gender stereotypes, patriarchy, ingrained patterns of discrimination outside the health system that permeate the health system, and often intersectional discrimination, as a number of people said. So I think those are all positive things to do. And there's no one country that is doing everything right, but I think there are clearly frameworks to learn from.
So I'm going to say something. I mean, it's really like obvious that every country is different. So I mean, in the Estonian case, I would start from having that missing research. So really looking at what types of obstetric violence people are experiencing, because that also, the Estonian context, I'm gonna assume based on what I've seen that we wouldn't have these very, very severe cases of physical abuse. The personal narratives that I'm familiar with are more about not having informed consent, no communication, and then some forms of shaming. But I think that's the starting point in Estonia, to actually know which types we're talking about, and then also kind of going to these root problems. Because in the Estonian context, I was thinking about, I mean, there are some people who actually work in hospitals listening to us, so they can correct me. But I would say that in the Estonian context, the material conditions are really good for people giving birth. Of course, more in the capital, but I would say that they're good. So I think that is not necessarily the problem. And about power, I think one of the issues that I've seen is that exactly sometimes healthcare professionals, they don't see that the work that they're doing is so important, that they have that power, and thus they also have the responsibility. But then it's not just about these individuals, because you can be that midwife who is very aware of human rights and how to put consent into practice and all of that. But you're constrained by the hospital policy, you know, that you can commit only 15 minutes to a patient, or you have to do this, or you have to do that, or you're overworked, underpaid, then these structural issues are going to get to you, even if you are someone who is aware of what is obstetric violence and is doing the best that they can. And I think for Estonia, I mean, I have done like a thorough legal analysis, but I would say that it's not the issue of missing norms, but it's really these everyday practices. But maybe after doing, because I think also the way Estonian legal system works, you can really use the international norms and the constitution, and you can construct all of these obligations also already using the existing norms. So I'm not thoroughly convinced that there needs to be a legal definition saying what is obstetric violence and what is not. And I think one good example that Estonia has for ourselves is how we have really come a long way with gender-based violence, domestic violence. It's such a difference how it's talked about and how it's treated. If we compare 5 years ago, 10 years ago, where it used to be very much of this, oh, it's a private issue, you know, we're not even going to like deal with that, and you know, this is how it is, and all of that. And there's been a lot of work in gender-based violence and intimate relationship violence, domestic violence, whichever term we want to use. And I think it's the same thing with obstetric violence, that there needs to be a lot of this awareness raising and trainings, and then discussion, and then kind of this very open discussion where also healthcare professionals, exactly, they have that safe space to have those self-reflections and with the help of other specialists. So I cannot really give you this magic solution, but I think every country needs to do that work, and then, you know, see what is missing in that scheme. Thank you.
Yeah, can I add just something? Because yeah, everything that you said is of course true, but there is another thing, and it is that we should, I mean, the legal system is one thing, and women know that they can, you know, I don't know, sue someone who did some malpractice and stuff like that. The problem is why they don't do that. And it's actually because their experiences of obstetric violence are silenced, and they're normalized, and that normalization of women's passivity that I was talking about, I think it is actually a huge problem. That it is, well, no matter how good laws we have and how good regulations are, it doesn't matter if people do not use them. And they don't, it is not that they don't use them because they don't know that they have right to, or because it is because of some, you know, institutional obstacles. I mean, maybe sometimes because of institutional obstacles, but because their traumatic experiences are so normalized and so like, you know, yeah, they are normalized, and then they just think that they do not have any reason to actually sue someone or to, you know, go into any legal procedure. And what has to be changed actually on the global level of thinking is that, you know, to give voice to women who actually had the experiences of obstetric violence, to listen to them, and to try not to normalize it in the next generation.
A lot of things were already said, and we said that legislation and legal framework is one thing, and of course reality and all these measures that we named, such as awareness raising, then trainings of medical staff, which is also necessary, improvement of working conditions. All of this is very important. So I would say that we need to introduce some comprehensive measures to improve the situation in practice. But still, I would not neglect legislation, and also legal remedies, because why women are silent? Mostly because they know that they will not achieve, they will be re-victimized mostly in some cases. So if they decide to go before some, I don't know, courts, and especially in criminal proceeding, they will be investigated and questioned as they committed a crime and not a doctor. And this is the reality that we live in. But then there is another challenge here, and this is what we already said. In order to introduce obstetric violence as a term, we need to have a definition. And we here named different forms which can be understood as obstetric violence, but at the same time, there is a lack of definition in international arena. And we see that legislation in some countries introduced this term, but in Europe, according to my knowledge and my research, there is no country which already introduced this term. So we really need to go from the definition in order to tackle this issue. And if law fails to reflect women's experiences and its limitations in the context of gender-based violence, then we will have impunity, the limit to access to justice, and we will not have responsibility of those who should be responsible for these crimes. So in a way, it's really important that we have comprehensive measures, and for that, we really need disaggregated data. Data are important from the perspective to be aware of different forms of violence which is happening, but at the same time also this intersectionality approach requires to see within women's groups who is more susceptible to this form of violation. So yeah, it's a very hard, but it's a good start, because in Serbia, since we had some reports, and more and more reports are coming, but every time when there is a possibility for women to report to some, let's say, independent investigator, they will report many cases that they went through. So in a way, it's really important that after this case that we had in January this year, many women appeared, and they were empowered to say that they were also exposed to different forms of violence and mistreatment, and it's a good starting point. But if we do not have a Ministry of Health who is aware of the problem, and also in a way ready to further investigate the case, and to also change the protocols, or to monitor the protocols and hospitals, then we will not achieve much. So in a way, a lot of things are connected here.
Do you maybe have an answer to Professor Krstić's kind of dilemma? Is obstetric violence defined in Estonia or America? And how do you kind of know how to recognize it and how to fight it?
But this is what I said. But I think that, Liiri, it's a question for you, for Estonia. Yeah.
Yeah, we don't have a legal definition for it. But yeah, I mean, I think my answer cannot be like a full one, because I haven't done that full legal analysis. So as a lawyer, I have to say that I cannot really answer that right now. But when I've researched sexual and reproductive rights in the Estonian context, many of these violations that can happen with sexual and reproductive rights, we don't have those specifically spelled out in laws, but with this we have constitutional rights, non-discrimination, right to bodily autonomy, prohibition of degrading treatment, gender equality. So I think the same with, for example, having access to safe abortion. We have an abortion law, but it doesn't, even if we didn't have that, I would argue that the legal obligation is there through this core human rights. But I think it's also a matter of, it's a matter of choice. and I think there's no right or wrong answer. We can argue that, you know, if you put the obstetric violence definition in law, that you will get some results, but it only goes this far. You will still need other things as well. So when it comes to gender-based violence, for Estonia, what made the difference was the Istanbul Convention, because that forced Estonia to amend the penal code, and also like to actually put domestic violence in the penal code. So, you know, sometimes that is necessary especially for judges who are not so keen on doing that kind of analysis, or prosecutors. So I think this still needs analysis, I think, but I wouldn't say that it needs to be one or the other. I think, you know, it depends on the situation. But yes, we do not have a definition for obstetric violence, and I think you're right saying that there is no European country that has put obstetric violence in a law with an actual definition. I don't think so.
Alicia, what do you think about this? What about, I mean, you work in America, right?
I live in the United States and I teach at Harvard University, but I have lived and worked in many, many countries, including many of the ones in Latin America that have enshrined legislation on obstetric violence, and many of the African countries that I had slides of before previously. The United States does not have obstetric violence legislation, as I said in my presentation. We use something called tort law, which is about civil wrongs, delicts, which is completely not the same. My own personal view is that enshrining it in legislation is significant, not just for the material consequences that it can bring about, but also because of the epistemic change. Law doesn't just resolve disputes, it also sets social norms and discourses, it also structures institutions. And the idea that obstetric violence is defined in legislation can promote different approaches to medical education, legal consciousness shaping and raising. So I think that that's probably quite important in the menu of things that need to be done. I do want to underscore what Liiri said, which is that each country is different. What happens in Estonia would be completely different from an approach taken in the United States, would be different from an approach taken in Brazil or Mexico or Argentina, would be different from an approach taken in Uganda or Kenya. And that's really critical.
Okay, thank you very much. I would now go maybe to questions from our audience, unless someone else has anything else to say, add to this. No, okay. So the first question, and I'm not sure if you will know this, but let's try. Is there a link between obstetric violence and postpartum depression or other forms of mental health complications? Milica?
So I suppose it was for me. Yes, there is a link, and it depends on well, the link is stable. It depends on like which mental health outcome do we measure, but there is the stable relation that indicates that women who had an experience of obstetric violence are at higher risk of not only of postpartum depression, but also of post-traumatic stress and general psychological distress. So that is another reason to think about, you know, about how to deal with obstetric violence on a global level.
Sorry. Okay, we have another question. What about ethical issues? How to normalize ethics among professionals?
well, I'm not sure if I could have like an answer to that question. It is actually really, really complex. I don't know if any other speaker has the answer that would be like more concrete. But I think that well, it is not only about it is of course about the ethics, but more about how we communicate and how healthcare workers communicate with the patients, because there is, I mean, I don't think that on a global level it is so much the problem of ethics, but what we do with it. So that's why I think that you know, some things like thinking about how you communicate and you know, because all of those things are, I mean, for example, women before giving labor, they sign a consent to, you know, to get under any procedure if needed and blah blah blah. So that means that, you know, ethically, well, it is okay, they signed the consent, but the problem is, what do we do with that? So how we present it, do we really inform, are they really informed, or they just signed it because they had to and stuff like that? So I think it's a much deeper problem, and I'm not quite sure how to, I mean, the solution is not simple, and I'm not really sure where to start from. I mean, from like healthcare providers, or from somewhere, you know, from some rules and regulations that would then regulate that.
If I can add something, Milica, to your point, because you're a psychologist, is very important in relation to ethical codes, but we know that each profession has its own codes. So I would say that in order to normalize it, first of all, we have to impose disciplinary measures to those who are breaking ethical codes, because within medical staff and also within the legal profession, we see that those disciplinary sanctions are very rare. And also to have trainings, discussions on some ethical issues, which can appear, and I would say also the reaction of our colleagues is very important, because according to some reports in some areas, for example, when we speak broadly about discrimination cases, we have those reports which are published and also researched by the Commissioner for the Protection of Equality in Serbia, that, for example, among public servants and also even judges and prosecutors, when their colleagues are aware that they are breaking the ethical codes and that they discriminate someone, they will not react. So I think that also empowering colleagues to react in those situations would be the necessity.
Can I just add? Oh, sorry.
Go ahead, Liiri.
So I was going to say that I mean, the consent is a good example again, because I think the problem sometimes with this, like, informed consent, I mean, we have that as well, but what happens is that exactly, a patient is signing a paper and, you know, is being even informed in that moment, but consent in human rights does not mean that you, after you have signed a paper, your consent does not need to be asked again. So I see consent more as a process. So when I talk about consent in human rights with midwives or gynecologists, it needs to be constant. So it's not like someone signs a paper, you're done with that, you're done with consent, you're done with human rights. So I think it goes back to the ethics thing. If it's just somewhere there is this document that has those guidelines or ethical guidelines, that's, you know, it can be a tool, but it's not enough. Like, it needs to be part of every decision, every act. So and I think this is a question also for healthcare professionals, like, how do they actually put those ethical guidelines in practice? And if they don't, why not?
So I'll just tagging onto what Liiri said and then going back to the bigger question. looking at comparative examples, what Liiri said about consent and international human rights law is exactly right. I mean, there's jurisprudence from the Inter-American Court on Human Rights and IC versus Bolivia about active information. So making consent more of a process and not waiting for the woman to need to ask, well, what am I signing? What does this mean? What are the risks? But actively providing information that has been reiterated, or in fact may have come from the Colombian Constitutional Court in jurisprudence on the health system. It's in guidelines and protocols in Argentina, legislation and protocols. So we can learn things. This is not we don't need to reinvent the wheel with obstetric violence. The same issues about changing consciousness and changing providers' behaviors have come up in many, many issues in reproductive justice before. I have given many talks and workshops for congresses of obstetrics and gynecologists in a variety of different countries. It's a tough sell. They don't internally understand that what they're doing can be considered violence. But nonetheless, I think we really have to refrain from thinking we're reinventing the wheel, because we have experience in maternal health, in abortion work, in other kinds of gender-based violence to do this, right? It's not legal or this, it's both and.
So we can call you then to give us lectures on this, Alicia. There is a question for you. Can Alicia speak of the success or not of the legislations introduced in Latin America, obstetrician legislations?
So I think it's had mixed results, frankly. And legislation doesn't operate in a vacuum. It doesn't enforce itself. So it depends upon a whole configuration of different actors. There has certainly been pushback from organized obstetricians and gynecologists. And in fact, in Europe, in Spain, where the CEDAW cases have happened, in Italy, there has been significant reaction from the medical profession to feeling like they're being punished or criminalized. And I think that's something we need to take seriously, not just say, oh, well, you know, whatever. And it's actually quite similar to efforts, since we have some psychiatrists and psychologists, to the reaction to the psychiatric survivors movement, where psychiatrists and mental health professionals feel like they are being attacked and criminalized, whereas there are structural problems and not individual behavioral problems. It's complicated. Each context is different. But you know, I do think we need to be aware that there is this pushback. There are many committed feminists who actually prefer the paradigm of disrespect and abuse to obstetric violence because it yields this pushback. So I think on balance, my own position is that the epistemic shift is absolutely fundamental. And is worth the others, but the way in which obstetric violence advocacy is done needs to be quite nuanced, so that we're not taking a punitive approach to individual providers, which is not worked in reproductive health in other arenas.
Okay, and there is one more question that kind of leans on what you just said, so maybe somebody else can give their own opinion. Physicians and obstetricians are often in a defensive stance when systemic criticism is awarded. Often the answer is not all of us. And they often mention the hard decisions they have to make in short time. Is it possible to make partners with obstetricians, gynecologists, or in any systemic change, or is any systemic change necessarily painful?
Yeah, I can answer that. The short answer is it is possible. It is possible. It can be difficult, but to be honest, talking about gender-based violence issues with judges or even attorneys working in law firms can be tough for another lawyer. So, you know, the tough audience thing, this is not something to be too scared of. And from Estonian experience, there are always people, healthcare professionals who agree with what you're saying, so they can become your first partners, and then you move from there. And I think kind of exactly like Alicia said, like we have to be aware of that pushback, be kind of ready for it. So even during these little trainings that I've done, there are always these people who maybe less rudely, sometimes more rudely point out, yeah, it's all beautiful what you're saying, but, you know, in practice, I have that many patients and, you know, this and this and this. So you need to be prepared for that. And very often these answers actually come from themselves. Like they describe the processes that take place in hospital. What is the decision process, how it works, what doesn't work, and then, you know, like you can together find the answers. Sometimes you can't, but, you know, at least you're working together. And I think this has been the most effective way of communicating this, because yes, if you just kind of from top down say, okay, you know, this is the obstetric violence definition, you know, this is the law, now, you know, put it into practice, it's just not going to work.
Okay.
May I add something?
Yeah,
Sorry.
absolutely.
Yeah, it is definitely that defensive point of view that comes from healthcare workers who say not all of us. I would just like to illustrate it, and then we can maybe discuss it a little bit. When there was this last case of obstetric violence in Serbia, like this January, there were many obstetricians and gynecologists who actually spoke about that loudly, and who were talking about making that it is necessary to be partner with the woman who is giving birth, and that they practice that. And they were, I would say, brave enough not to say not all of us, but to say, yes, some of us do that and it is wrong. So it means that they already, well, some, and it is probably the majority actually, they were just quiet. But many of them actually have that attitude that kind of partnership during the childbirth is essential for the procedure to go, you know, right and safely and stuff like that. And then the problem are not those people. The problem are those who actually use and abuse their power position. And it is not, I mean, when we talk about this, it is not that we are criticizing everyone from the healthcare system, all of the physicians and nurses and midwives. No, it's just important to know that many of them are aware that partnership relation is actually needed, but we have to focus on those who are not aware of that, and who actually, well, they might not do it on purpose, they probably do it accidentally, but they abuse their power, and then we need mechanisms to prevent them from abusing their power, because you cannot expect a vulnerable woman who is like laying and giving birth to, you know, rethink the power relations in our society.
So yeah, well, maybe I don't know. I know you said that every country is different, every experience is different. So I don't know if you can answer this question, but there is a question that says, what should be the first step in fighting against obstetric violence if it is a systemic issue? Which kind of activities give the best result? Can you give us some positive examples, but if they can be kind of concrete? I know maybe it's a difficult question because, as you said, it's different for different countries, but here we go.
Who is that question for?
Well, I suspect maybe Dr. Liiri and Dr. Alicia, given its, positive practice from, I guess, abroad. I mean, or advice how to start fighting it.
Yeah, I mean, I said before in the Estonian context, it would be actually having that data research. That's also my academic background talking, but obviously there can be different activities at the same time. So awareness raising, the legal analysis, whether norm reform is needed. So one doesn't need to necessarily wait, but yeah, I think data and research is what would be needed in Estonia.
Alicia?
So I am always in favor of data and really deliberately thinking through methodologies to collect that data, which I think in this case, from past experience, needs to be both quantitative and qualitative, almost ethnographic. But I also feel like, I mean, I said both and, like, I think legal and policy change is necessary. I think educational change is necessary. I do want to say one thing because I think we are actually still talking about, and it's unfortunate that Dr. Pickles couldn't participate, slightly different things. So are we focused on abuse in obstetrics and gynecology, or are we focused on changing, not people who abuse their power, or are we really challenging the power of obstetricians and gynecologists and the medical profession? And I think that is quite a significant distinction for moving forward. We don't have time to go into it much here, but I think it is quite a significant distinction in terms of what direction advocacy would go in. The second thing I would say is, as much as I think this issue is about democratizing health systems, both for frontline providers and for users, as well as program designers, et cetera, that circle I showed in my slides, this goes way beyond the healthcare system. Providers inhale misogyny and patriarchy in their educations because that's part of our overall societies and the patterns of discrimination and disadvantage that women and and trans men face all the time. So we can't separate out how people are behaving within healthcare interactions from the larger social issues. Law helps to change those discourses, but it also requires a lot more than that, right?
Thank you. Now, I think this would be a question for Professor Krstić. How can the institution of the Ombudsman help combat the rise of obstetric violence in Serbia?
Yeah, thank you, Jovana. I'm always in favor of submitting complaint to the Commission for the Protection of Equality, because I believe that this is the form of discrimination. But also, ombudsperson can monitor public institutions. And for example, in January, when we had this case which appeared, then the ombudsperson also invited women who believes to be victims of obstetric violence in the past 6 months to report the case. So the ombudsperson can monitor and issue recommendations, and also for women who are in institutions. And Liiri mentioned, for example, detained women, but we also have women in psychiatric institutions, in some social care institutions. So what ombudsperson can do, also monitor that closed institutions and see what's going on, because one of the forms which appears in practice also can be ill treatment or even torture. And I'm so glad that we also have Milica today with us, that she also was one of the authors of this comprehensive report that was conducted in Serbia in 2022. And in that report, they recognized 16 forms of obstetric violence in practice. So I think that it deserves attention. And if we speak about the next steps, I think that that report is a very good starting point to discuss what measures we really need to introduce in Serbia in order to tackle this issue.
Thank you. I have one more question. Milica mentioned bribes. I'm interested in how much corruption has to do with cases of obstetric violence, especially when it comes to medical providers who are careless because they feel that they are protected by their powerful, maybe political acquaintances, or even the legal system, especially in Serbia. But maybe this question can also be for Professor Yamin, given she worked in Latin America, Africa, I suspect. Maybe these things happen there as well. Milica, would you maybe start?
Yeah, but I don't think it's actually a question for me, because it's actually more of a legal question. What we know is that women who do have enough money and resources to give bribes feel safer, because that is kind of a guarantee that everything is going to go well. But also those who have more money also sometimes choose to give birth in private hospitals. So it's another way of, you know, of having like a human treatment. But I'm not really sure. I don't know if well, how it could be, the corruption problem could be, you know, combated, and what, you know, to do with it in our legal system. It's out of the scope of everything that I know. So yeah.
Can anyone else try and give us an opinion, perspective?
So anecdotally, in my own experience, I think that there certainly is evidence of providers requiring payments under the table, et cetera, so I have worked on maternal health and reproductive health in many countries on many continents. So that I've seen that in sub-Saharan Africa, I've seen it in Latin America. In fact, I've seen similar things, almost not quite under the table payments in the United States. So that is one kind of corruption. There are other kinds of corruption where money leaks out of the system and doesn't get to the things that would make the material conditions appropriate for women to be delivering. And that's, I think, an even bigger problem. Often when they're under the table payments, it's because frontline healthcare providers are not receiving salaries or receiving adequate salaries. And so they ask for extra money from their patients, et cetera. So there are often structural conditions that produce that. I think there are some kind of institutional corruption issues in health systems that produce obstetric violence of different kinds, as well as, for example, the overuse of cesarean sections that is incentivized by reimbursement schemes, et cetera. And I think that you know, that can probably be extended to some other issues as well. So corruption is certainly an issue, but it takes many forms.
Okay, thank you very much. Does anyone else have anything else to add?
Maybe I want to just to, in the case of corruption, because what Alicia said, yeah, corruption has many forms, and it's maybe not directly linked to our topic today, but for example, in this case that we had in January this year, we had a woman, and we also have many women who also monitor their pregnancy in private practice of doctors who deliver the baby at the end. And in this case, the same doctor also monitored the pregnancy, but it was not a guarantee that she will not went through obstetric violence. So as Milica said, in some cases, maybe it can be like assurance for a woman to feel safer, but at the same time, it does not mean that it will avoid the violence itself because of everything that we already discussed and said.
Okay, so I will try and conclude and summarize everything we said so far. Obstetric violence is not disrespect and abuse, but we don't have clear definition what it is. Shared decision-making and the pathologizing of birth are most important aspects of fight with obstetric violence. Serbia has no mention of obstetric violence in the law. There are many different ways to legally react, but legal remedies are not very effective at the moment. Material conditions in hospitals for delivery are very, very poor, which probably reflects the attitude towards women, as we said. Informal norms are the most problematic, and they need to be addressed outside pure laws. Medical professionals are often not aware of the very large power they can carry. And even when they are aware of structural aspects like length of control, they are preventing them in implementing the practice, implementing these things in practice. So we need to empower our colleagues to react. And no matter how good laws are, they aren't useful if people don't use them due to normalization of traumatic experiences. Women are often re-victimized, investigated, and questioned as if they have committed a crime rather than, faced one. Informed consent, communication, and shaming are basic aspects that can be addressed. Informed consent, especially, is hard since patients often don't know what they are signing. And also it is ongoing and needs to be asked continually, which is probably hard during giving birth. So I think we can conclude that, as we said, every country is different, every case is different, and there is no magic solution, but we probably have to start addressing these things and start solving it, and hopefully with positive practices from other countries, we will manage to find a solution together. I want to thank you all for coming and participating. I want to thank our guests for dedicating their time to share their valuable knowledge and experience. A long journey is ahead of us, but in order to address obstetric violence, we need to have information and ideas on how to do it and where to start. I hope you found this panel informative and inspiring, and I hope we will all continue our fight together. Završit ću samo na srpskom. Još jednom hvala svima na prisustvu. Za kraj samo želim da vam dam informaciju da se Institut za mentalno zdravlje u Beogradu bavi reproduktivnom psihijatrijom i da se pomoć pruža svakome ko doživljava poteškoće, bilo u planiranju trudnoće, tokom iste i nakon porođaja. Tako da slobodno se javite, potražite pomoć, pričajte ljudima o ovom panelu, podelite ga kada bude na YouTube-u i hvala vam svima na učestvovanju.
And Jovana, maybe one more remark, just because we did not address all the questions that we had, so I encourage our participants to get back to us according to our expertise, and maybe we can continue discussion on this matter. And once again, because this was the event organized in cooperation with the law faculty, I also want to thank you all for having time to come and to discuss today this important issue. And Jovana, thank you, the Institute, for this great cooperation.
Thank you so much to all of you.
Thank you.
Thank you. Thank you. Thank you for inviting.